So, good evening, all of you. First of all, we'll start with our class today. It's a relatively defined topic. It's a staging of the lung cancer. Lung masses can come as a long case. They are also something that we'll frequently encounter while we are practicing because we have a good population, good number of population of smokers. So we know that lung cancer is more common in smokers. So we'll try to see how we do the staging and what all modalities can help. So why is staging in lung cancer important? What all modalities are there? And how and when do we actually, select which modality to use? So in lung cancer, remember that it is a leading cause of death. Out of lung cancer, we subclassify lung cancer based on its histopathology. So most common histopathology is a non-small cell lung cancer, which makes up the 80 to 90% of the chunk of the lung cancers. Why is staging important is because staging is the most important in predicting survival as well as in choosing treatment options. So remember that survival is related to the stage of the disease. And staging directly correlates with mortality. So higher your stage, more is your chance for mortality. Staging will also help us decide whether we can go ahead for a curative surgery. So in staging, what are the components of staging? First is the tumor itself and its extents. Next is lymph nodes, their stations, their extent. And then is metastatic lesions. Metastatic lesions that is within the lungs, in the same, whether they're in the same lung, opposite lung, or whether they are in extrathoracic locations, that all also is important now. What do we choose for TNM staging? We go ahead and we use the American Joint Committee on Cancer, the 8th edition. So remember, 8th edition is the one which is currently in use, and it has been in use since 2017. So there is now an expected 9th edition and is expected to release in Jan 2025. International Association for Study of Lung Cancer is the main group which can provide us with the primary source of information on how to work on this. So now we come directly to the point, right? I will show you some cases in the end so that we can actually think and choose what we are going to do. So tumor staging. So this is that primary mass which we see, right? Another important thing is so what all modalities are available for us? So how can a chest X-ray help us? It can only help us find a nodule which may be growing, like, it was smaller earlier and now it has increased in size, or we can see a full-fledged mass, or we can even find that one half of the hemithorax may become opaque because of a mass and effusion, depending on what stage it is, right? So chest X-ray is basically just to either, it's not even a good modality to screen. So I will not use the word screening here. But whenever we pick an abnormality, it is usually on a chest X-ray. Next will be a CT, right? So in CT, what are we going to do? Whether we do a non-contrast or contrast, we will do a contrast enhanced CT. Why? Because we not only want to see the mass and its enhancement characteristics, but we also want to see whether it is involving the adjacent vessels and whether there is pleural disease as well. So the contrast will help us in seeing whether the pleura is involved, because pleural deposits, they'll be enhancing, they'll be nodular. with how the mass itself is, and the vessels, vascular involvement, right? And then is the lymph nodal status. So we know that lymph nodes are not very well visualized on a non-contrast CT. We can see when they are enlarged, but to characterize them adequately, we need a CCT. I will also talk a little bit about PET-CT and MR, right? That we'll do later. So now we already know that how and when. So we know that chest X-ray usually first to pick. This is what brings the patient to radiology. And then we go ahead and do a CCT chest. Later, as we read the staging, we will know what to choose next. Okay. So now that we've come to the primary mass, so what has happened here is that so there is a tumor. Tumor means a collection of neoplastic cells which are multiplying. So first of all, if they're only growing along the surface, right? If they're only along the surface, they're not invasive, right? So then it's a carcinoma in situ. Okay. This is when you catch it really early, and that will usually be a bronchoscopic finding. Next is T1. When your tumor is less than 3 centimeter, within this, they have created 3 subcategories at every centimeter. So why this has been done? Because for every centimeter, your prognosis is worsening, right? For your every centimeter growth of the mass, your prognosis becomes poorer. So we have T1 less than 3. That means for every centimeter, that means T1A is up to 1, T1B is up to 2, but more than 1. And T1C is less than 3, but more than 2. Next, we go on to T2, 3 centimeter to 5 centimeter. And after 3 happens when the mass is more than 5 centimeter and less than 7 centimeter. So what happens? This 1 centimeter concept works up till 5, and some books say up till 7. So then these are the limits at which this has been set. The whole idea of tumor staging is that we know what is the prognosis and what is the outcome. So once that is decided, we know just by looking at the primary tumor itself that what can be the stage. So these are the size criteria. Okay. So whenever we see a mass, we have to see the size criteria. Next is infiltration into adjacent structures. So this is very important because what is going to decide everything will be this. So this is very, very important. So when we say stage T2, so this is in regard to the tumor itself. Whenever there is a main bronchus involvement, then it is called a T2 tumor. Now, whenever an airway will be involved by a mass, we all know that for a mass, the best sign will be an airway cutoff sign. That is sometimes how we actually suspect a mass, when we see that there is no air going distally, right? So for that, there has to be a bronchus involvement. If there is a main bronchus involvement, then that means there will be distal atelectasis, right? There'll be a distal atelectasis because of the obstruction. We have an airway. These are the airways which are filled with air. And in case I have a mass sitting here, then no air can go distally. So all of this is going to get devoid of air, and this all part of the lung which is being supplied by this airway will undergo atelectasis. So whenever there is obstructive atelectasis, irrespective